Thank you for joining us. You are a part of a powerful group who recognizes that Black women's health should be at the forefront of the national conversation. We are mothers, daughters, activists, entrepreneurs, entertainers, corporate warriors, and more, who help boost the economy and often drive the national conversation. For almost 40 years, the Black Women's Health Imperative has strived to amplify our voices, help enact policy that protects us, research our issues, create programs that enhance our lives, and produce events like this one to ensure we keep the conversation going about the issues that matter to us most. So, let's get started with our program.
Good afternoon, welcome, and thank you for joining us. Today we are having an important conversation once again about driving the conversation on Black women and maternal mental health and what's especially happening in areas that we often overlook. Today we're going to focus on the South, specifically Mississippi. And this conversation is so critical and important because Black maternal mental health or mental health issues are the leading cause of death for maternal health pregnancy outcomes. So when we talk about Black maternal mental health or mental health in the realm of pregnancy and postpartum, those are the leading causes of maternal death. I don't know if you all remember Miriam Carey. She was 34, she was a dental hygienist, and she was killed by the police in 2013 after a high-speed chase through Washington, D.C. that led to a lockdown in Capitol Hill. And it was said that she suffered from postpartum depression. And I remember all of us thinking in 2013, maternal mental health in terms of that wasn't a topic of conversation. We all assumed she had that postpartum. We all thought that we didn't realize at the time that that was really not postpartum depression, but more like postpartum psychosis. And so there's all these different terms that we're going to uncover today about maternal mental health, what's happening in our community, why it's the leading cause of maternal deaths, and we're not really talking about it or uncovering the issues. And we're going to get into some really important research that the Black Women's Health Imperative have done in this area, and with some really important researchers in this area that have been working on this work for a very long time. So I am Dr. Kanika Harris. I am the Senior Director of Maternal and Child Health for the Black Women's Health Imperative. And I am now going to start introducing our esteemed panelists for today. First, I'm going to start with Dr. Karen M. Sheffield-Abdullah. Dr. Karen is passionate, and her passion centers around stress and anxiety in Black women. She focuses on utilization of holistic, integrative, multi-sector strategies to promote physical, mental, and emotional well-being for Black women. She is particularly interested in offering strategies to reduce the long-term health effects of stress, psychological trauma, anxiety, and depression on women's health and birth outcomes. Her interests include the biophysiosocial benefits of self-compassion, mindfulness, and other mind-body therapies as adjuncts to conventional treatment and modalities. Dr. Karen has a doctoral degree in nursing from the University of North Carolina at Chapel Hill and a master's in nursing degree from Yale University. She is a certified nurse midwife, mindfulness instructor, and mother of 4. Her vision is to create a society where Black women are seen, heard, and valued. We have Toni Junious, MPH. Toni is a women's health researcher, arts and wellness curator, healing artist that merges public health and holistic practices to promote wellness as liberation. Toni currently serves as the Maternal and Child Health Program Manager at the Black Women's Health Imperative. Through a holistic approach, Toni blends health equity, sexual and reproductive justice, and empowerment to address the root causes of disease and help our community heal from the inside out. She received her master's in public health and global health epidemiology from George Washington University And she also graduated from the University of California, Irvine with a Bachelor's of Arts in Public Health and Global Cultures. She is a certified yoga teacher, community health herbalist, and trained full spectrum doula. As a healing artist, Toni curates spaces and experiences for her community to have supportive, fulfilling, and healthy journeys in birth and beyond. Next, we have Dr. Nikia Grayson. Dr. Nikia Grayson is a reproductive justice informed public health activist, anthropologist, and family nurse midwife who has devoted her life to serving and empowering people in underserved communities. Nikia is Chief Clinical Officer at Choices Memphis Center for Reproductive Health, where they have opened up the first nonprofit comprehensive reproductive healthcare center in the country and the first Burse center in the city. She is also a member of the board of directors for Sister Reach, the only reproductive justice organization in Tennessee. Nikia is a graduate from Howard University, HU, with a bachelor's and master's degree in, I lost some notes. I'm so sorry, y'all. And she also has a bachelor's and a master's degree, I believe, in anthropology and journalism, if I am correct. And our last panelist is Dr. Nakeitra Burse. Dr. Nakeitra Burse established 6 Dimensions LLC in an effort to strategically respond to the health needs of the community. As a native Mississippian, she is well aware of the impact of poor health on the environment, the economy, and the overall quality of life for individuals and communities. She is also acutely aware of the impact of systems have on individuals and communities. Dr. Burse has been entrenched in public health for over 10 years, earning a BS in biological sciences and an MS in health education promotion from Mississippi State University. She holds a doctorate in public health from Jackson State. Dr. Burse's previous work in public health includes experience in the nonprofit sector, state agencies, and academia. As a result, 6 Dimensions LLC was born to create strategic, sustainable, and innovative solutions to public health with a focus on health equity and social justice. So thank you for that. And thank you for our esteemed panelists. Hi, everyone. Thank you for being here. So we are going to start with just what is happening in the context of maternal mental health in this country. What is it? What is going on? How is it affecting the Black community? Dr. Karen, can you just start us off with some context to this problem and what is happening?
Yeah, thank you, Dr. Harris. So what I would say is that, in full disclosure, I am very interested in psych mental health, particularly amongst Black perinatal people and Black women. And while we study depression quite a bit, we don't study anxiety nearly enough. And we also know that anxiety during the perinatal period is actually quite prevalent. And we also know that Black perinatal people are impacted by maternal mental health conditions, but we are half as likely to receive care or seek treatment. And so what is going on specifically surrounding maternal mental health for our community, and how might we be talking about it differently than other communities, and how might we be interfacing with our healthcare providers in a way such that we're being missed? We're being lost. We are not having our needs met. And we also know that while depression and anxiety often coexist, not everybody who is anxious is depressed. And so really thinking about what are the unique and nuanced ways in which the Black perinatal population is talking about their anxiety. And it does sound different than the global minority. And furthermore, how are we actually capturing it with the existing screeners that are out there, right? So we know that there are screeners that are out there like the PHQ-9 or the Beck Anxiety Inventory or the Spielberger State Trait Anxiety Inventory that might be out there to help assess anxiety for different communities, but there's actually an anxiety scale called the perinatal anxiety screening scale that is thought to do a fairly good job of picking up anxiety in perinatal populations. The question is whether or not it accurately picks up anxiety in the Black perinatal population, and specifically thinking about it in the South. And so that is what we set out to do, is to ask the key questions and do something called cognitive interviews. And with cognitive interviews, you're basically asking the question, not just, oh, how, let's say, as you're looking at item 1 here on the screen, not asking the person necessarily, how often have you worried about the baby or pregnancy, but we're asking, what do you understand that question to be asking you? When you hear that question, how are you interpreting that question? And in the way that they respond, is it the way in which we would expect them to respond given the question? So we performed these cognitive interviews with 20 Black perinatal individuals. And what you can see here is that we asked the question, over the past month, how often have you experienced the following? With cognitive interviews, we stop right there. And we say, what does the past month mean to you? And some people would say, oh, the last 28 days. Some people would say the last 30 days. Some people would even say, oh, it's May 21st. So I think all the way back to April 21st, or maybe early April. So the past month can even mean different things for different individuals. What you're seeing here, if we just looked at the past, is a 31 item scale. And what you're seeing here, let's just take item number 1 and how they answered. We said, over the past month, how often have you had worry about the baby/pregnancy? When an individual sees that question and they answer it, we as researchers, we don't necessarily know, or the people who are scoring this, we don't know if they're answering about the pregnancy or the baby. It's what we call a double-barreled question, right? So the suggestion might be that for future iterations of this type of scale, you break that out into 2 separate questions. Worry about the baby, and then the next question would be worry about the pregnancy. What we found in the cognitive interviews is that the majority of individuals were actually answering about the baby and not about the pregnancy when we further probed or asked questions about that. Another thing that came up when we asked these questions, if you look at item number 7, when we talked about really strong fears about things and then said needles, blood, birth, pain, they actually answered about each one individually. Right? So when we're asking somebody that type of question and they might respond almost always, you don't know what their actual fear is that they're responding to. So there are several questions in the questionnaire that are what we call double-barreled or triple-barreled. If we go on to the next slide, I want to highlight for you item 14. You see there where we asked the question, difficulty stopping checking or doing things over and over. What we found is that there was a comprehension issue here, because they were like, that just doesn't make sense. Stopping checking, right? They didn't understand. So they kept saying, can you repeat that? Can you repeat that? So that difficulty stopping checking, or what we call that double gerunding, that ing, again, just wasn't quite making sense, understandably so, right? So thinking about how we might word that in a different way, that would make it easier to understand. Similarly, in item 15, feeling jumpy or easily startled, double-barreled, right? And those aren't necessarily the same things, feeling jumpy or feeling easily startled. If we look at item 18, where we talk about upset about repeated memories, dreams, or nightmares, again, that's triple-barreled, right? Because we're asking them about memories, dreams, or nightmares, and they also connote something different. So memories doesn't necessarily mean something negative, where nightmares they associate as something negative. So just understanding that there's complex nuances within the way in which an individual might answer these questions. If we go on to the next slide, which I think has the remaining questions there. One thing that I did want to highlight here is item 24, where we talk about how often have you felt detached, like you're watching yourself in a movie? What was really interesting with this particular response, when individuals, Black perinatal people, were responding to this, they responded like almost always. They were like, oh yes, I feel like I'm watching my life in a movie. But it wasn't because they were detaching. They weren't dissociating, which is what this question is actually trying to get at. That's not the way in which Black perinatal people were actually interpreting this question. They were like, yes, I feel like my life is a movie, right? Like I can't even believe all the things that are going on in my life right now. So really taking that into consideration when we think about the cultural nuances or the cultural differences or the way in which a scale should be culturally adapted or culturally tailored, to take into consideration the ways in which particular communities might be interpreting a question. So I think those were the main items that I wanted to be able to kind of call out for individuals to be thinking about as we went through and did those cognitive interviews. Then we now have recommendations for the ways in which that scale could be improved.
Thank you so much. I want to back up a little bit because we went straight into the research. Can you give us some context around what happens with us in this country in terms of perinatal mental health?
Yeah.
What is it? What's the difference between postpartum depression, postpartum psychosis, and the term we're using now is perinatal mood disorders as well. It's been here for a long time. We know it's the #1 cause of maternal deaths in the country, and yet it's often overlooked, and does not get enough attention in terms of how we're talking about the scope of maternal health in this country.
Well, I think one of the biggest things to take into consideration is the fact that you cannot have physical health without mental health. Right? They're inextricably interwoven, right? They are connected, if you will. And so if we're not addressing mental health for an individual, it can absolutely have impact on their physical health. If we think about during the perinatal period, where we know that Black maternal morbidity and mortality is much higher amongst the Black community than it is amongst white individuals or our white counterparts. Black women have twice the rate of preterm birth and low birth weight infants compared to their white counterparts. And if you also take into consideration that stress is a key contributor, right, to preterm birth, anxiety is also a key contributor to preterm birth. And there are unique experiences, both racism-related stress, gender-related stress, and the intersections of both of those that absolutely contribute to our mental health as well as our physical health. And so wanting to be able to think about how can we really take the time to listen to Black women in meaningful ways, to really make sure that we're showing up in culturally humble ways to say, how might I best take care of you? What are the things that I need to know in order to be able to take the best care of you? And then also normalizing the conversation surrounding mental health, so in particular, depression and anxiety, and then how that looks different. Anxiety is typically, we're associating that with excessive worry, right? Excessive worry or fears about things. With depression, we're more concerned, while there can be an anxiety component with depression, we're more concerned about not wanting to take care of yourself, not able to take care of the baby, feelings of extreme sadness or loneliness with depression, right? And then with psychoses, there's also, really kind of detaching from reality as well, and having thoughts of wanting to harm yourself or harm the baby. So there are distinctions that are made there. And what I think is really important is that we're screening all the way through pregnancy and into the postpartum period. And we're not waiting until the 6-week postpartum visit to have that conversation surrounding their mental health, but thinking about that dependent on what their mental health concerns may be during pregnancy. at least by the second week. Whether we think they have mental health concerns or not, we should be following up with individuals to see how they're doing with their mental health, because there's this extreme hormonal shifts that happen after we have the baby that can cause also mental health concerns.
Thanks so much for that. And so I'm hearing a difference between how we think about maternal mental health overall. A lot of times we're thinking of postpartum depression and mental health. When you get to the psychosis part, that's what we're thinking about usually when we say postpartum depression. It's kind of like a catch-all for all these things. And for Black women, what we are experiencing is very, very different. What I'm hearing you say is we're experiencing racism in this country, sexism that affects our pregnancy and birth outcomes in different ways. Additionally, we can also have some of the traditional ways we think of maternal mental health or postpartum depression, postpartum psychosis, which is the chemical imbalances that we're normally given. But I'm hearing for Black women, it can be very different. And we need to look at a more complex picture that not only can affect our birth outcomes for Black birthing people in this country, our birth outcomes, but also additional stressors on the postpartum end as well.
Absolutely. Yeah, no, I was just going to say really quick, like, if we think about discrimination, interpersonal racism, structural racism, right, bias, all that can impact the care that we receive during pregnancy and the way that we interface with the healthcare systems. It absolutely can impact the way in which we navigate our pregnancy, the care that we receive, the relationship we have with our healthcare provider, which can absolutely impact our mental health. And you tack onto it now all the hormonal changes that are happening during pregnancy, and whether or not even our own families as well are sensitive to the changes that can happen, the changes in mood, what's normal, what's not normal, what to be looking out for. And then also just thinking about, without getting into too much detail, but there is something called Superwoman schema, which is the way in which certainly many Black women can show up. And there are like 5 different hallmark characteristics of Superwoman schema, which is maintaining a stoic exterior, emotional suppression, resistance to being vulnerable, determination to succeed despite limited resources, and the caregiver role, even at the detriment of our health. So when we show up to the healthcare provider's office, if we have a stoic exterior or resistance to being vulnerable or emotional suppression, they assume that we're okay. So they're not asking the questions. But if you take a moment to actually ask the question, the way in which we may be talking about it might be, I'm just agitated, I'm irritated, people getting on my nerves, right? Like I'm not sleeping well, I have a headache. It may sound more like that, but that is an opportunity to have a further conversation surrounding their mental health, surrounding asking something like, when in the research that I've done, when I've asked folks, are you having conversations with your healthcare providers surrounding your stress and psychological distress? There's a resounding no. And then I say, would you have wanted to, right? Because within this stoic exterior, emotional suppression, do you want people to ask you? Do you want your healthcare provider to ask those type of questions? And they said yes, but only if they're going to have the resources to send me to that are going to take my insurance, that is going to be able to see me in a timely fashion, and that's going to be stellar. They want excellent care. They don't want to be referred out somewhere that's not going to provide really good care for them. So that's another aspect of healthcare, and certainly Black perinatal mental health to take into consideration, the ways in which we talk about our mental health.
Thank you so much for that. And that was one of the key take-homes that we found in our research at the Black Women's Health Imperative, that when we were talking to pregnant women in the postpartum period about their experiences, they were flying through the Edinburgh scale, like just not tapping onto any radar around maternal mental health issues. Passing it with flying colors. The questions around, do you have the baby blues? Are you blue today? we're just not mapping on to Black women's experiences. So we decided to go a little deeper into that research, uncovering those racial and gendered experience that we're experiencing. Also, the economic, social determinants of health that we're experiencing, that we don't tap into these questions as well. When I see the PASS scale, understanding that it's getting closer because it's testing stress and anxiety, but when I hear it and I think about me in the postpartum phase, I still don't think those questions would map on to my experience per se. I know it gets us closer, but I'm still thinking we have some ways to go in terms of really mapping the Black experience and what we have. But we use the PASS scale for this research, absolutely. And we can see just initially, I think, what you found was basically, I think, probably what any person would find too as well, any mother, or birthing person taking that could have those cognitive issues in terms of, not cognitive issues, but a different interpretation in terms of how they would look at those questions. I'm going to, Toni, would love to pull you in and tell us more about the research that you led at the Black Women's Health Imperative around the PASS scale and the cognitive interviews, and we did some additional focus groups. So tell us about that process.
Yeah, so hi everyone, I'm Toni, Junious, she, her pronouns. Research is limited about perinatal mental health disorders across the US, but especially in the South and especially with Black women. And for our research project, we did ask the participants like how they identify. So we know that birthing people are not limited to women, but our participants did identify as cisgendered women. And so we focused on Mississippi specifically, one, because we work with, Dr. Burse and her team, 6 Dimensions, on the ground there. So of course, doing, community-based research, we're working with partners who are there, but also because Mississippi has a very high maternal mortality rate, and they also have what we call maternity care deserts, or where there's, lack of access to OBGYNs, rural hospital closures, all of those things, which Dr. Burse and Dr. Nikia Grayson will go into a little bit later. But for our research, we really had a 2-part approach. So Dr. Karen really went into the details of our PASS scale cognitive interviews that we did. So that was the first part of the research, was to just ask the women, like, is this scale actually make sense to you? And with Dr. Karen, essentially, they were like, no, this doesn't really, which is what we assumed. And there's a lot of other new kind of scales coming as well, but we also wanted to get the Black women's experiences when they're pregnant and postpartum of their anxiety and stress and any barriers that they were experiencing to mental and emotional wellness. And so we also did focus groups. But for our cognitive interviews, we were able to have 20 pregnant and postpartum women who Dr. Karen and Dr. Wallace interviewed. And most of those folks were in the Jackson or like the metropolitan area. And then for our focus groups, we had 4 with 25 pregnant and postpartum women total, and Dr. Burse's team, 6 Dimensions, led that effort. And I was able to go down to Jackson last spring and be a part of the in-person focus groups. And then we also did some Zoom focus groups to include women in the Delta region, because I don't know if the folks joining were aware, but around last spring, there was a devastating tornado in the Delta region. And so that just, exacerbated the women's mental health experiences that they already were going through. So we did take time to make sure that their actual emergent needs were met. And then we came back and did the rounds of our focus groups with those women. But it was really illuminating to be able to not only have the scale, the quantitative elements of how this is or is not assessing Black women's needs, but to also have space for them to share, because a lot of the participants are like, oh, no one's ever asked me about my mental health or how I am. They only ask about baby, or they only worry about baby's health, like Dr. Karen had mentioned. And So we could probably get into this later, but a lot of the women talked about like a village and how that's how they're able to survive and thrive at this point, and whether they were still pregnant or postpartum. And then some of the women even brought their babies with them to the focus group. So to be a part of this has just really made an impact, not only on our research, but in the community, as I'm sure Dr. Burse will share.
Dr. Burse, I guess you're up. Would love to engage you in this conversation and pull you in. Can you just give us more context of what's happening in Mississippi, how this affects your work, just in terms of being in the South? No one is really talking about the South. The South is never really on our radars. We're always talking about the West Coast or the East Coast, and then the South is just kind of out there. What's happening, and why is this work so important?
Yeah, first, thank you all for this conversation. Thank you for the timely research. And I will say it was really a pleasure to be a part of this research team. And we do say, what about the South? And we are often overlooked. But one thing that we here on the ground see a lot is that we're not overlooked when it comes to research. And so one thing that I really enjoyed about this was the intentionality of the research and how we went about conducting everything, because it is very often that people come in, get the research, and then desert us with and leave us with no resources. And so I think that's a big piece of this puzzle. I know we're talking specifically about the mental health outcomes, but we cannot talk about it without talking about the big picture and how the systems come into play when it boils down to resources that are needed here. And so a part of what I do also is serving on the Maternal Mortality Review Committee for Mississippi. And I've been on the committee maybe for 4 or 5 years now, and have seen about 3 reports come out from our state. And as we have progressed, and our reports now cover from the first one covered 2016. And so now we have data all the way up until maybe 2021. And we have seen a progression in maternal mental health issues that impact outcomes. And so that's anything from, depression, postpartum depression, to substance use, and so many different factors that are playing a role that we can link directly to maternal mental health. But then we have to still take another step back and look at what the conditions are. Mississippi is a mostly rural state. And from any point, we have about maybe 2 metropolitan areas, the Jackson, Mississippi area, which is where I am in it's our capital city area. So that's one metropolitan area, and then the Gulf Coast, and then up toward Memphis, where Dr. Grayson is, we, kind of teeter on that line. And so if you look at how rural our state is, in an area like the Mississippi Delta, where, as Toni mentioned, maternity care deserts, then you're looking at potentially 2 hours of drive time to any location or any provider. So you may not have enough OBGYNs. That's one thing. But then you don't have emergency care situations. You may not definitely don't have access to a lot of mental health resources and support. And so just the rural nature of our state creates a lot of barriers around healthcare quality and access. And then when we take a bigger step back, and this year our legislature did not expand Medicaid. We have been working in conjunction with many, many organizations here in Mississippi for the past 4 to 5 years, and it's been longer than that, but to really, really hone in on this Medicaid expansion issue, and we still have not expanded. Last year, we did get the extension to 1 year postpartum, which is a good thing. But then the water is still muddy around what does that look like. Providers say, well, how do I even use this? who do I connect folks to? And are there even people in my area to connect people to? And then as a parent in this, how do I use my benefits? And what is the communication around what benefits are available to me? So though that was a big win for us in this bigger Medicaid expansion issue, it still doesn't, it's just not enough. It's not enough. And so we're only one of maybe 12 states, I think, at this point that have not expanded. And those of us advocates on the ground really felt like this was our opportunity. And so we don't even know what the future looks like. We're about to jump back in it to try to strategize on what the future may look like for healthcare access in Mississippi. But there have been many, many cases, and I say many, and when I say many, we can point to 2 or 3 specifically, and that's too many, around women who had to drive a long distance, did not have access to care. And it's really, if anyone has ever served on a maternal mortality review committee, it's gut-wrenching, especially, everything is, of course, de-identified, but when those cases come across that tend to be that were out in the media, it really jolts at your heart to know that our deaths, 87.5% were deemed preventable by our committee. And so this issue of maternal mental health continues to grow in the state, but we are very under-resourced when it comes to the big dollars that could come and solve those problems. The advocates here on the ground are working overtime to fill in the gaps, but then there's still not many resources to even cover some of those things. We're getting referrals from our state offices for issues, and we don't even have the funds or resources to cover some things.
Thank you for that. And I wanted to engage you and Dr. Karen and Toni as well on what were the findings that we found from the research that happened on the ground, because we're talking about the provider side, which I want to engage Dr. Nikia Grayson in on from the provider side. What is she experiencing as someone on the ground? But I would like us to delve in first about the findings from the research and where are we with this?
Yeah, I can share a little bit about our focus group findings. So with the Black pregnant and postpartum women, they were really vulnerable in sharing their stories and experiences of finding care, right? We've been talking a lot of the lack of care, but we were fortunate to hear about the things happening on the ground in Jackson, Mississippi, specifically with like Mom Me, a bunch of other organizations that Six Dimensions also work with. So that was helpful to see like what actually was working, right? Like if there are these gaps, if there are these, care deserts and stuff, like what are the women doing? And so they helped us kind of connect those dots of like what is working. And a lot of them, which I was illuminating earlier, we're talking about how that communal care is really important. So, right, like a lot of the overarching healthcare systems and structures are lacking, but the communal care is helpful. They talked about having doulas, especially Black doulas. I can't remember if any of them had a midwife, but I know they had a few Black doulas that they got for free through different community programs, and how some of them mentioned that being like, life-saving for them, of having someone advocating for them. Some women went through loss before, and so navigating healing through trauma, and what does that mean for your mental health as a Black woman in the US, in the South. And so those are different things that came up. And with the providers, it was really interesting because we also did focus groups with providers, and a lot of them were like, either they do the screening scales and they try to make referrals, but they know that sometimes it's not really going to end up with adequate care that's sustained. But also some of them kind of were like, I don't screen, or they feel hesitant to screen because, like Dr. Karen and Dr. Burse mentioned, there is not really a strong funnel to refer their clients. And so that was something that we saw from the provider focus groups, was like this provider desire for better resources and for better screening tools, because the ones they named, of course, were ones that weren't culturally tailored. And so, yeah, that's some of the things that came out of the focus group research.
if I could just add really quickly, I think the biggest piece is, to my knowledge, there are no culturally tailored anxiety or depression screeners, period, right? So that is what is so novel about the work that we did. That is the gap that we're filling, is that we are the ones that are the first to be looking at this in this way, through doing cognitive interviews, through doing focus groups, to really think about, are we capturing what we set out to capture? And I will say that it's not easy from a healthcare provider perspective, right? As a midwife of 20 years, when I think about, and I would say that I'm one that has done my work to be able to have conversations and normalize conversations surrounding mental health for perinatal people. And even with that knowledge base, it still can be difficult, because if you have somebody who comes in who scores high, let's say on a depression screener or on an anxiety screener, but they're not acute enough that you feel like they need to be immediately seen, right? You know what I mean? But they're not well enough that you think that they can wait 3 months to be seen. Then you've got this in-between space, right? Where psych often says, oh, they're pregnant, go to OB. And OB says, uh-oh, it's a psych issue, go to psych. And in the meantime, who is the one that's suffering? It's the client, it's the patient. And so what we're wanting to do is to really think about, how do we, from the provider perspective, think about what the resources are that are available for our patients, and also being able to hold space and navigate if our patient says that there's something acutely going on, or they're vulnerable enough to share that we can get them in a timely fashion. And also thinking about the fact that a lot of times Black perinatal folks aren't willing to share that vulnerability for fear of CPS showing up at the hospital when they deliver their baby. You're going to try and take my baby away from me. So really, there's a lot that we're trying to navigate, both as healthcare provider and advocating for our patients, and making sure that we're actually asking the questions that matter. Right. And so there's a lot of nuance there that we're taking into consideration.
Yeah, absolutely. And please, Dr. Burse.
No, I'd only want to add to when Toni talked about communal care. Trust is the biggest thing around that, because as we have programs and projects, we typically recruit, and so they become like this community. We all become this community, and it's a trusted community. And so it's really hard for other folks to come in, or for, the families that we are working with to even go out to other services. So like, as much as we can, trying to provide as many coordinated services together in one spot is really, really important.
Absolutely. And I think that's why it's key that Black women, of course, and people are just at the helm of this issue and solving our own problems. We have our own researchers, we have our providers, we have our midwives, and we know that when we recruit, when we do the research, we're going to go back to that community with the information. So we do have a plan to re-engage this community and say, hey, here's what we found from what you said. Here's what we plan on doing about it. Here are what we're doing in terms of policy recommendations. Here are some things that you can do to learn about policy and advocating in your community as well. We thank you for engaging in this, and we're going to together collectively work as a part of solution, understanding that lived experience makes you an expert and makes you a valuable asset and needed and wanted in this space, that you don't need the credentials or the letters, or we're doing this and engaging on this together. So I think that's very important about the work that Six Dimensions does and why we engaged them for this. We wanted someone local in the community that could help us with this research, and really for these women to be comfortable, to be to commune as we're talking through the research as well, which is the experience that happened. And then also through research, you can bridge community, you can bridge solutions right there as well. And would love to talk to Dr. Nikia Grayson, who has an amazing, amazing reproductive health and birth center that She leads in Memphis, Tennessee, called Choices. I got the chance to visit. It is, I mean, I just couldn't dream of something more phenomenal. So I would just say, if you're there, don't bug her too much, but see if she can give you a tour. Dr. Nikia, what are you seeing as a midwife? Yeah, what are you
I
seeing?
mean, everything you all talked about is, definitely resonated with me in NIC, and definitely being in the South has been a very different experience. We know that, Black women are more likely to experience, maternal mental health disorders, but are less likely to receive adequate treatment and compared to their white counterparts. And a lot of factors, of course, contribute to that, and, including underdiagnosis, stigma around, you know, associated with mental health, and a shortage of course, culturally competent mental health providers. And that's a lot of what we are seeing. And when we started our midwifery practice here at Choices in 2017, it was really important to me, leading that project, that we focus on a holistic approach. We recognize that we are not just caring for pregnant people and worried about the baby. We had to care for that pregnant person, and really that family that new person was going to go and be with, right? And so recognizing also that midwifery to me was the answer for our community. It was really for us to reclaim and restore those practices, those communal practices, and the way that we care for each other was really important. And so, like Mississippi, we did not expand Medicaid in Tennessee, which is unfortunate because the reimbursement rates are so low, and so few providers are willing to care for patients who have Medicaid as their insurance. And so we found this huge provider desert because we had nowhere to send people, and people were less likely to care for families that were on Medicaid. So one of the things that was really important to me when we started our practice was that we centered families that were on Medicaid, and we centered Black and Brown families and helped them to really get the care that they deserved, right? And so our care model is different in that it is midwifery led. And at that time when I started to practice, we didn't have many midwives in the community, and definitely they didn't look like a community. And so now we have 6 Black midwives here at Choices, and there's only about 1,000 Black nurse midwives in the country. So what was really important to us was that we grow more care providers that were rooted and grounded and trained from a reproductive justice and social justice perspective, and recognizing that we have to partner with our community, and we have to partner with the people that we're caring for. And what we've seen is that we've had some tremendous outcomes, and by doing that, because we had to really start to address the structural racism and all the other isms and issues that we were facing in our community. And so in talking about mental health, we of course know that the GAD is extremely flawed, and one of the things that we talked about in our care was really being a village for the families that we were taking care of. So we did implement we have a group model, as well as we have a hybrid model, really, where they do see individual midwives individually, but they also we have group care, because what we found is that people feel like they're in isolation, and that the things that are happening to them, the things that they are experiencing, are just they're experiencing alone. And what they found was in this group model that they saw others who were experiencing those same things. And so we have group models throughout the pregnancy, but also like Dr. Burse said, when we also were able to get them to expand the postpartum period to a year. But what does that mean? It doesn't mean anything. It means that they have insurance for a year. But I mean, like she said, many providers were questioning, well, what can we do with this? So one of the things that we did was we keep our patients for that whole year, and we have a postpartum group that they are a part of for that whole year, and we have partnered with local counselors to help to evaluate patients and who we can do a warm handoff with as well, which is so important because they had nowhere to go in the community, and we were diagnosing people, but we had nowhere to turn to for help. And so what we found is that 1 year postpartum group has really been transformative for many of them. And we've been able to partner, like I said, with a local counseling group here to be a warm handoff for them. And that counseling group also comes to our clinic and talk to them and are part of that postpartum group as well. And it's been really, really phenomenal to be able to see a lot of the transformation in our patients because of that model of care. But like Dr. Burse said, even in Tennessee, Mississippi and Tennessee are a whole lot alike. We've seen the poor maternal outcomes and poor and maternal deaths, and in the 22 maternal mortality review committee's report, they said that all of the maternal deaths, 100% of them, were preventable in the state of Tennessee. So we have to do something different.
Thank you so much. And one last point that we have 2 midwives on this call. That's very intentional, very intentional. We are hearing about worldwide how midwives and doulas are the missing solution to preventing these deaths and dealing with preventable deaths in maternal health and maternal mortality. And just creating a more vibrant, joyful experience through the perinatal process as well. So this is just not about you. I'm a near miss survivor. That is just not my goal in life. We do want to thrive and survive and feel joy, especially within that first year of cuteness, of baby cuteness. Everybody wants to feel that joy and remember that time. And we know that we need community, we need support to do that. And I feel like that is one key medicine to solving this issue. Where I don't think a lot of it is rocket science. I know we're looking at different medications and for our really severe cases, and we're grateful for that research and that happening. But I think in general, we're looking at isolation, we're looking at lack of community, we're looking at lack of really normalizing what happens in that perinatal process and that postpartum process, especially for Black women who want to be seen as we carry and hold it all, and we don't want to look like we can crack sometimes.
Yeah, well, first of all, everybody deserves a midwife. Okay.
Yes, absolutely. That's right. Everybody deserves a midwife.
Everybody deserves a midwife, which is why, one of the things that was really important to us here at Choices, and one of my dreams was to be able to grow our community here, right? And so when I started, I was the only Black community midwife, and we had 2 Black doulas. And so for us, it was very intentional that we, do doula trainings to help grow that community, to partner with lactation, the lactation community, and help. We only had like 2 Black IBCLCs to help grow that community. And so what we've seen is that over these last 7 years, it has grown exponentially, but that community is really important. And, partnering with local therapists. We have very few therapists. I'm not sure why people are scared of pregnant people, but they do not provide care to pregnant people. Like Dr. Karen said, they will kick it right back to midwives or to OB and say, hey, that's a psych issue, and or that's a pregnancy related issue, and they're really afraid of that. But we have to start having these conversations and start recruiting local counselors and therapists to help with that. Now, people who need more care in terms of prescription meds and things like that, therapists and licensed counselors cannot do that. But then we have, psych mental health nurse practitioners and psychiatrists that can help in those areas. But I think that we have to really have more of these conversations about what the community is experiencing and how we are failing them.
Absolutely. Absolutely. Thank you for that. We had everybody deserves a midwife, so you do not have to see a midwife just if you're pregnant as well. You can, any reproductive health issues, you can see a midwife. That's important. I had to tap Dr. Nikia and be like, hey, check me out. I can't get to the services I need right now. So yes, everybody deserves a midwife. We had a few questions from the audience that I just wanted to tap and ask. Um, One question is, do we know if there's any research around Black maternal mental health and climate change? Does anyone have any insight into that?
I don't know if there is around mental health, but I have seen on the rise a lot around climate change and Black maternal health and maternal health in general. So I'm seeing that that's a trend in the direction that we're going.
Yeah, absolutely. So one of the policies in the Momnibus bill does focus on climate change and maternal health, especially dealing with those urban kind of heat situations where we're experiencing high heat that can lead to preterm labor as well. And I know we just dealt with the flood last year in Mississippi and the hurricane and a lot of those other issues that are coming up. So I think we'll definitely look more into that. And then another question we have is, what can therapists do in the field?
Well, one of the things that I would think about, and I love the fact that Dr. Nikia also mentioned like psych mental health nurse practitioners, right, and licensed clinical social workers, because one of the things that Black perinatal people also have talked about is preferably having a healthcare provider that is racially concordant, right, or have shared lived experience. And we know that there aren't large numbers of providers that are Black mental health care providers. And so with that being said, I would say that healthcare providers in general can take the time to do their work, right, and to really understand and the ways in which different communities might talk about their mental health, and just kind of holding space and being, as I've said earlier, culturally humble, right? I don't necessarily say culturally competent. I don't know that I could ever be confident in somebody else's culture completely, but I can be humble enough to say, what do I need to know, right? If I'm taking care of somebody who identifies as Indigenous or American Indian, what do I need to know about taking care of you? So I think as mental health care providers, also in terms of understanding not only the differences that there might be culturally, taking the time to understand how you treat mental health conditions during pregnancy, and that we are not necessarily counseling individuals off of their psych meds during pregnancy. There are cases in which you may need to do that, but for the most part, somebody who is stable, right, on their medication, we are not automatically trying to taper or wean them. As somebody who has also served on the Maternal Mortality Review Committee here in North Carolina, looking at all the substance use and overdose deaths, as I've reviewed records, it's amazing to me how many individuals were counseled off of their medications during pregnancy, and then were surprised when they have exacerbations in their mental health concerns, which also then can also be linked to their substance use, right? And so really thinking about as mental health care providers, how we can educate ourselves on what exactly are the recommendations for management of different mental health conditions across the perinatal period and even into the postpartum period.
Thank you so much. And we are almost at time, but before we leave, just a quick round of policy recommendations. What would you like to see change in order for us to move the needle on this issue and for us to get the care and the support that we need?
Yeah, I just want to plug that we did put in the chat, but we have a whole policy paper that we'll be disseminating soon with folks that have like a lot of more detail of from the research, the different policy recommendations that we had. But kind of the main buckets are like what Dr. Karen was kind of alluding or talking about was improving healthcare quality, which includes increasing, racial concordance in healthcare and having programs to make that actual happen structurally. And also going beyond implicit bias training, but also having accountability measures for clinicians that are providing maternal health services across the spectrum of perinatal care. We also have some recommendations on like ensuring access to care, and so creating a maternal health workforce council, especially in the South and Mississippi, things like that. And Dr. Burse mentioned how Medicaid was not extended in Mississippi, but policies to ensure that those will get done in the future. And then increasing support for Black mothers, I think, is super important. And of course, across the spectrum of perinatal care, so pregnant and postpartum, so that's up to 1 year after birth. And one thing our team shares more in the paper is like paid leave for both parents or all parents to, it's more than just having access to therapy or medication, but to actually have time with your newborn, have time to rest, to heal, and especially if there's any trauma that happens during the birth experience. And we have the National Maternal Mental Health Hotline that we can put in the chat. But again, these are different resources that have come out recently that are helping, but also our research really illuminates just the need for developing comprehensive screening tools that are designed for Black birthing people that actually will help us get the care we need. So I kind of quickly highlighted most of our points, but if Dr. Burse or anyone else on the call wants to share more, especially on the ground in the South, I'll open it up to y'all.
I would just say really to fight for and advocate for full practice authority for advanced practice nurses, psych mental health nurses, midwives. We really can address these maternity deserts that we are experiencing in our communities, but also to see expansion in telehealth to help reach these areas where we see these maternity deserts as well.
Yeah, and I just want to add a few things on top of that expansion of broadband as well for our community, especially the rural communities, to be able to even access the telehealth opportunities. And I will continue to say expanding Medicaid, full expansion. And also, I think even policies around midwifery that support building the workforce of midwifery and building I guess maybe creating the good opportunity for midwives to practice in Mississippi and policies that do not hinder that. And then also really expanding the scope for doulas to be able to practice and potentially bill for Medicaid and other services as well.
Thank you. Thank you so much. We thank you for your time today. As you see, we all have the answers. Just listen to us and implement these things, and the world will be a better place. Make a Black woman a president, and we will solve all things. But I want to thank our guest today, Dr. Karen Sheffield-Abdullah, Toni Junious, Dr. Nakeitra Burse, and Dr. Nikia Grayson for your time today. We couldn't cover everything in an hour, but we've covered a lot. And I just want to thank you, and we will see you soon. Thank you. Have a good day.